Good. Good morning, everyone, and welcome to this panel on building health systems for Africa. My name is James Kiawoin. I was a member of the inaugural class. I'm from Liberia. I'm currently a graduate student at Princeton University, and I spend most of my time studying about how you improve government institutions to deliver access to healthcare and thinking about ways how we can fund universal health coverage. And I'm very honored today to share the stage with three people who've led by the eloquence of their actions more than their words in our rebuilding health systems in Africa. So before Princeton, I spent 2 years in Liberia working for Last Mile Health. And the mission of Last Mile Health is to, can you hear me? The mission of Last Mile Health is to bring access to healthcare in the world's most remote villages. And over those 2 years, I was fortunate to see people who every day, like frontline health workers, going above and beyond to ensure that people have access to healthcare everywhere and every day. So today, I would let my three panelists introduce themselves very briefly before I start asking questions about how we can think about rebuilding health systems. So we're going to start there. Yeah.
My name is Deko. I'm a physician from Somalia. I run a hospital outside of Somalia, but my focus is on women's health and children's health. I work with MSF, Doctors Without Borders, as a pediatrician, although I'm a gynecologist. That's what means being an African physician. You have to do everything. So I wear multiple hats, but my passion is healthcare and human access to healthcare.
Thank you. My name is Deo Gracias Nizongiza, but you can just call me Deo. It's the easiest way of remembering my name if you care. I was born and raised in Burundi, rural Burundi, and went to school there, primary school, secondary school, and part of medical school, and went to the United States in 1994. Did my studies again, grad education, and 11 years after, working in Haiti in different places with Partners in Health. And those of you may know Partners in Health and Dr. Paul Farmer, who's a great friend of mine. I went to Burundi 2005, and that was 11 years after being away. I knew that Burundi had suffered a lot, but what I didn't know was the conditions in hospitals in Burundi that were so dehumanizing, making people who were, many of them, brought into hospitals from internally displaced camps, lose hope and watch themselves die in hospitals. So I asked myself, how could anyone find happiness again in these conditions? So I went back with Burundi in my heart, in my mind, and started an organization called Village Health Works. We started the health organization and integrated other programs, economic development programs, and education, nutrition, agriculture, and so on and so forth. This organization is truly a community organization. We mobilized community members who were former enemies and became collaborators and friends. And we've, in that community, donated the land, 20 hectares of land we have. We have a wonderful person from the community, Ladus, who is here at LA. She's going to take over my responsibility. That's me. Thank you very much.
My name is Muhammad Pate, and like my colleagues here are all physicians. Most of my work has been in primary health care in Nigeria for 5 years, leading the immunization effort to eradicate polio, to revitalize the primary health care system, to improve immunization systems. So these days I spend my time in global health and development. I lead an organization that supports national leaders. It's called Big Win Philanthropy. That works in several African countries.
All right, thank you very much. So across our global health, and in Africa specifically, we see what I like to call the triple convergence. There's the dual burden of malnutrition. You have people who are obese, and then people who are like food starved. There's the dual burden of diseases. We're seeing like communicable diseases continue to be the primary drivers of mortality and morbidity. And we're seeing the rise of like cancer and other non-communicable diseases. And much recently, we've been seeing cuts back in global health funding, a further threat from the US and like other countries to like scale back their global health funding So the question is, how do African governments choose their priorities? And what option exists for domestic resource mobilization to fill this financing gap? Start with you.
All right. So I think, look at the bigger picture, the demography within the continent and the demographic transition. There is aging, youthful population. NCDs are coming, and there will be more NCDs, non-communicable diseases. So it's not triple burden, it's actually what I will say quadruple burden. Right. You have the maternal, newborn, and child health issues. We have the lingering infectious disease problems of HIV, TB, and malaria, which are still fragile in terms of the progress. You have emerging, re-emerging infectious diseases, Ebola, Lassa fever, monkey. These are with us and will continue to be with us. Thirdly, you have the issue of trauma and new forms of trauma, because you have urbanization, you have dislocation, you have you have lots of other issues that are coming. So within that context, how does African health systems actually fit in that? It's one thing to go the path of other advanced economies to build health systems that actually respond to the curative side. I think our challenge is to really think more the preventive side, to really refocus on prevention as much as we're dealing with the care, because that's sort of where the big buy is, and our system should be oriented in that way, because the resources are limited. So if you do the prevention bit, you actually do the more cost-efficient interventions that will prevent the diseases that ultimately will cost you more, even before you come to the resources that you need to do that. Secondly, for African leaders to also think about health not as a consumption thing, not where you spend, but it's an investment in their economies, in their people, and there are also dividends that they can get from that. And so prioritization of health is not a marginal issue, it's a very central issue. When you ask Africans all across the continent, according to BBC surveys, the number one issue that affects the people, that actually people care about, is health. And yet political leaders don't mirror that level of prioritization. But beyond more resources will only come when governments collect more revenues as a whole, so that they have smaller portions of really bigger pies, so collect them better. But also within what they collect, allocate health, because it's an imperative not only for just delivering services every day, but also for their economies to grow in the long run, because about the human capital. It's also important to say that the inefficiencies within most health systems could be significant, maybe not more than 10%, but 10% could be a significant number when you talk about the amounts that are being spent in health, to actually plug those leakages, corruption, and a few other ways that we actually can stretch the dollar spent. So in sum, it's not just about putting more money from the finance ministry, but stretching that money through prevention, through primary healthcare systems, stretching it by allocating better in those areas where you can actually get the bigger bang for the buck, but also plug in the leakages in the health systems.
Yeah. Well, I agree with everything you said. When you talk about the role of government's priorities, I think every responsible government should know that where there is health, there is hope. As the minister here said, I don't think that we can expect any country that has people dying from totally stupid death to become a country that is going to get anywhere in terms of development. In terms of the gap in funding and donor community and resources, it's really not for lack of resources in Africa. We have plenty for our people and plenty to share with people outside. But why is it that we're a continent where people still die from diseases that have been eradicated in the Western world centuries ago? It's a leadership issue. And it's a lack of imagination, to be honest with you. And it's corruption you were talking about. It's greed. It's not understanding the value of life of these, for example, coffee growers who are only known when they are harvesting coffee, and after that they are not known. The government of Uganda, for example, I hope I don't say something I will regret tomorrow. You pray for me. In 2012 alone, just 1 year, the government of Uganda spent $150 million on a medical evacuation of the elites to Western countries whose governments have had the good sense of investing in modern healthcare. At Village Healthworks in Burundi, we've been struggling for the past 10 years. How do we save mothers' lives, mothers dying in childbirth? When we talk about building a 150-bed hospital to do surgery, to do C-section and save lives for $20 million, we are told it's too expensive. And that money cannot be used for this kind of infrastructure. That same hospital, the size of that, in Texas, would cost about $800 million, but it's too expensive in Burundi, where there is, sometimes death seems to be more common than life. It's our responsibility. So it's not resources. It's really, it's who we are and how we value each other's life.
I think you both covered well about the government issues and how we should invest first, prioritizing our health. We cannot have an economically developed country without having a healthy community. If you don't have a healthy person, you not get work, you're not getting money. So Minister of Finance in Africa has to focus on healthcare. They should be friends with the Minister of Health. I want to make sure everyone gets the job healthier to make money and to grow the country. It's very important and it's very crucial. And yeah, it's the issue of spending our money going abroad. Everyone who can afford to go abroad, in my country, in Somalia, and most of Africa, we spend our money outside instead of building in Africa. We don't have access to everything. The main problem that government not only spending money, it's how to maintain what we have. In most of the countries, NGOs well developed a lot of small hospitals, build a lot of things, but no one manages them. It's empty. We have things, we don't have human capacity, we don't have structure in place, we're not investing in our human capacity, we're not investing in medical personnel. It's not only building the hospitals, we need to invest also our medical professionals. We cannot afford not having any transplant done in Africa, not having done anything to specialists. We don't have any specialists. Everyone in Africa, it's a general practitioner. If I want to find any specialist to send my woman who I see in my patient, I don't have. I just have to send outside of the country. So that's the areas we need to focus. It's also not only building and putting the money, the hospital is also putting the money in healthcare workers. It's very crucial.
Thank you very much. So I became interested in global health partly because of the Ebola crisis in Liberia, where I come from. And from what I've read about, like the post-conflict sort of recommendations and diagnosis of what actually happened, there seemed to be like a tale of two responses. At the international level, it's like ineffective transnational coordination and global stewardship. But then at the community level, we saw community health workers and people really rally up really quickly to actually end the disease from spreading. So how do we prevent the next Ebola?
Yes, I think first, after Ebola struck, I was really struck by the fact that in the region within which Ebola killed tens and thousands of people, first it took too long for the world to respond, and the response was mixed, but also the reflection as to what happened. A lot of it came from outside the continent. It took a while for the continent to actually come and say, look, we've lost 10,000 people. 1,000 were lost before even the alert was raised. Where would that happen in this world? And yet, the reflections as to what have we learned from that was very late in coming. There were several commissions. I happened to co-chair one of the independent panels on the global Ebola response with colleagues at the London School of Hygiene and Harvard University to look at the response. And yes, there's enough to be said about the global stewardship of global health, the international health regulations, and how countries' capacities have not been built. But there's a lot more to be said about our own domestic effort, our prioritization of the public health systems in our countries. We don't have to depend on, let's say there's a limit to what global solidarity can take us. National leaders ought to be able to invest in our domestic health systems to surveillance and use those community systems, leapfrog using technologies to be able to understand what's going on in our communities. The diagnostic capabilities themselves were very limited, and they still are limited for many diseases, cholera, meningitis, many infectious diseases, and there will be more of them. Even the flu that is ongoing, you hear reports in Australia, you hear reports in the north, but you hear very much silence in the continent. And is it because there are no cases or because we really don't know? And then the capacity to respond within our public health system, the external dependence has meant a lot of resources get channeled towards where the supranational priorities are. And yet the capabilities to respond when there is an outbreak and contain it has not been as much a priority. Fourthly, the research capacity within the continent. I think it's also very important. I don't think we've paid sufficient attention to that, because some of the solutions and some of the infectious diseases that we'll come to terms with are at the frontier. We're at the frontier, and yet I don't think our countries are investing enough. Leaders ought to be able to invest in the requisite capacities for today, but also for research in how to detect, how to treat. There's a lot of intellectual capital that can also translate into economic development. It doesn't have to be a large corporate in the north that actually does that. So talk about the Ebola vaccine. How many entities on the continent participated in the solution? I'm not just being critical. I'm saying that from the point of view of what have we learned and how do we position when something comes up in downstream, that African countries are part of the solution. And there will be more infectious disease outbreaks because human beings are not alone. We're interacting with pathogens all over, with animals. We're urbanizing, we're moving around, and infectious disease will come. But our public health systems ought to have that, and they have to be linked with community systems for surveillance, and leaders have to pay attention to that.
The case of Ebola is an interesting case. It started in 1979, I believe, in the Congo. Is that correct? I think even the name comes from this river in the Congo. Why did it become quite suddenly now such an issue? It's because humanity is on the move. It didn't become an issue of the Congolese or the Africans. It became also an issue of the West. And so attention was there. You know, you are from Liberia. A lot of flights were canceled. So that became an economic issue. And so it was not just because these Liberians and others were dying this way. Anyways, that is a side point. But the case, what can we learn from Nigeria? Why you are so close to Nigeria, but Nigeria managed to contain Ebola? Because they mobilized community health workers. They put together a health system that clearly worked. So what can we learn from them is basically to do what they have done and train our community health workers, send out your doctors. But we also should not be thinking about building clinics, build hospitals. If a community health worker is bringing a patient who is suffering or needs some attention, where do you bring that patient as a community health worker? To a nurse, to a doctor, to a health infrastructure. So Ebola was and is nothing but a symptom of a collapse of a healthcare system. That's what I can tell you.
So, I think it's well said. Nothing I have to add. I agree with you 100%. And everything is about the system and prevention. We don't do African prevention at all, and we don't have a human capacity. If we had, as a Nigerian, if Liberia had, or even any other any other country in Africa, we could prevent any diseases. And it's very sad because we don't have a human capacity We don't have health workers that train, and you don't need much. You don't need medical school 5 years, 10 years. Community health worker, it takes 6 months or even less. We just need a small time to invest and focus the basic thing. And it's reachable. If we say Africa we cannot reach, we can reach every village. Every village has a mother leader or a father leader or healer. Just to communicating with him, he can rally like thousands of other villages. We need to work with them also. When we say us who as physicians learn from West, we undermine them and we ignore them, we will not going to reach our people, and we cannot prevent any diseases as long as we're not working with them side by side. We need to train our healers, and we need to respect them, and we need to teach what we learn and work with them to prevent all that diseases. We cannot just come and oppose them. So, okay, this is what we learned from West, and this is what you have to do. We're just going to disassociate with our community. So it's very important to have a conversation and be close to the community as much as possible to prevent any diseases.
Thank you very much. So this is the final question I'm going to ask before I open out to the audience. So at the end of 2017, leaders of the world met in Tokyo to discuss universal health coverage. How do we ensure everyone has access to healthcare? And is the issue actually access or equity?
So we're here at the LA, and I think it's been a very inspiring morning, and I believe that that's a challenge. We've outlined the challenges facing African health systems. We have got these global commitments to get to universal health coverage that all over the world leaders have signed up to. But the path that we follow would be very different. Countries will follow their own path. One of the arguments I made earlier was really around people-oriented, community-based systems that actually ensures everyone has access to good quality service in their countries. In the context of Africa, I guess the LA and leaders over the continent will have to find those paths for their countries based on where they are in terms of their resources. They will need to innovate in terms of how to reach to the last mile and ensure that everybody is covered. But beyond coverage, one of the flaws, or not, what do I say? We say universal health coverage, but we also know that on the continent there's a gap between coverage and quality. That the increases in coverage we've seen last 10 years has not been matched by a commensurate increase in quality of care.
Right.
It's pointless to have access to a service that is of extremely poor quality, and poor quality costs lives as well. Estimated more than 1.7 million lives annually have been lost from poor quality care, and it costs economies. So as we look at the universal health coverage goals in terms of the mortality outcomes and all of those targets, and African countries take their path based on the resources available for them, based on the domestic resources, the capabilities that they will unleash. They will have their own path, but we should look at not only coverage, but also quality of what is being covered. It is possible, and I think Africa can be able to do that, but we'll find our way to be able to do that. That's a challenge for many of the young leaders that will be coming out of early as they get into their trajectory. In 13 years' time, we'll take a stock. I hope we'll do better than how we did with the MDGs.
That's correct.
Dr. Hadis, want to go second on this one?
I'm a big believer in universal healthcare access or coverage, and with my life, my mom done it. For what I know, for last 33 years, my mom was working to deliver healthcare as much as possible as a rural area, as a deep in Somalia, and it's very crucial. Everyone has to have access to healthcare. Otherwise, we are in a luxury big hospitals, we will receive most of the patient. I think almost 65% my patient is for bad healthcare access, or someone did it, or someone did wrong things. By the time they reach to me, it's already too late to do anything. So it's easy for me to get to them and to train them as much as possible to do the right thing, a basic thing, and prevent. And just if you cannot do it, just call me or give me, transfer this patient. The system has to be in a place. It's not only access, as you say, it's a quality access. A quality access, we need to work on it. We have to, as a physician is in Africa or in government in Africa, we have to stop talking. We have to do action. We have to go deep in our rurals. We need to sit with our healers. We need to deal with them. Okay, this is what you can do. This is what I can help you. It's not only just sitting and talking about the beautiful structure and how we can do it. We just have to do the action. It took my mom 7 years to other village to accept and come to our hospital. I just came from a village in the rural area, border between Somalia and Ethiopia. It took me 2 weeks just to sit, not see any patient. No patient came to me because they don't want to deal with me, they don't know. One day I spoke to the healer, I sit with them. Next day I was exhausted working. So it takes a patient and understanding how we want access to our people. And it's very important. It's not only building the hospitals and the structure, it's just talking to them and respecting them and working with them and teaching what we learn.
You've said it all. Maybe an example I can give you is the village health works. We are 99 kilometers away from the capital city, in a very remote area of Burundi, where people, most of them never had, saw a vehicle before we arrived. And we made the road that links the main road to the capital city to the village. Before, there was no such a thing. And it was made by community members simply because they heard there was something health center that was going to be there. And Burundi has probably more than 95% of the population are in rural areas. They are the engine of the fuel of the economy, and yet they are the ones who have no access to care. So it's an issue of access. Healthcare should not be available to those who are in the cities alone or to those who can pay alone. It should be accessible to everyone, and it should not just be about building tents as it is the case in rural areas for many African countries, but quality health care. We have seen a lot of patients. Imagine someone who is so sick, so weak, so desperate, is walking 7 days to our health center to find out after diagnosis that we cannot help. And then you send that patient back home with the news, death sentence. Breast cancer, cervical cancer, stupid death can be prevented. My wife, who is the clinical programs director at Village Health Works, trained at Harvard Medical School, is overwhelmed. What she says often, she said, Harvard didn't train me to deal with the poor things on poor people. So it's an overwhelming situation for healthcare providers who watch patients who are traveling by foot for days to be told, I cannot help you. It's almost like when you are an amazing swimmer, a champion, and you are watching a baby drowning and you are handcuffed. You cannot save that baby, and yet you have all the knowledge, but you have no tools. So we just needed to make sure that healthcare must be not only a human right, it's a development issue, and it should be accessible to everyone who really needs that. So that's the equity, and that's the access issue that we talked about, and we have no really other way around it. We've transferred so many patients to Israel for really surgeries that could be done in Burundi. So then you have to deal with some ethical issues. You have 5 mothers bringing 5 children who are suffering from the same conditions. How do you choose who is going to be transferred and what is the cost? We train our physicians in the Western world. What does it cost to train one physician in the Western world versus importing physicians from different parts of the world to train as many as possible on the ground where we are, but they can't because we have no infrastructure. And how much does it cost? It costs so much. So it's really, again, a lack of imagination. We can invest in the health of our people, and we can uplift our communities so that they can be productive, healthy community members who will make a great contribution to improving living conditions throughout the world.
Thank you very much. Do you have to leave?
Yes, I sincerely apologize that I have to.
Thank you very much.
Thank you. Yes.
No problem, thank you.
I have to catch a flight.
I have a question. Yeah. So we'll open it to the audience. We'll have you go first. That's you, yeah.
Hello.
Can you stand up?
Hello, my name is Eme. I'm from Burundi. And my question was to you all, how do you make sure that Africa in general reaches this self-reliance level where, like, for example, in Burundi, we have, we always see, like, on TV, children asking for help to government, for them to be sent to India or the US, you know, to perform some charity or whatever. Like, how do we reach this level where we don't need to send anyone outside of the continent of the country, or like we can do everything on our own without us always begging for help? Does that make sense?
You wanna go first, Amir?
It's dependent on you. Study medicine and come back to Africa. That's very simple. Very, very simple. Otherwise, if you all leave and have a comfortable life in the West and no one, doctors, we cannot give you access to anything. So.
And have an education based on a critical thinking, not on a rote memorization.
Right.
That is true.
We're gonna have you go right there. Nice clothes you're wearing, that's why I'm calling you.
Hello, my name is Zolani Medu. I'm a Mandela Road Scholar from UCT. So my question is also sort of linked to, well, all of you in his absence as well. So whenever we speak about health, there seems to be this trend of sort of speaking about it in terms of like physiological conditions and everything else. And I think, for example, the Life Esidimeni tragedy in South Africa is a clear example of what it means to sort of have a very exclusive healthcare system, or a healthcare system that isn't necessarily sort of reflecting its policies. So for example, on paper, South Africa does have a mental health care policy that very much stipulates what the process of deinstitutionalizing persons living with mental illnesses who have been institutionalized. So there's a process that is on paper, but we've seen sort of a contravention of that very process. So I'm very much curious in what your intake is, and how then do we sort of bring an African perspective into this policy, because deinstitutionalization is sort of a broader agenda that perhaps we've adopted from some Western idea. No one knows, it's a huge debate. So I want to know, how do we how do we impose an Afrocentric approach to strengthening healthcare systems within the continent, and ensuring that, for example, what you were mentioning, a mentally ill person in a village may not necessarily be exposed may not necessarily have the same access to resources like someone within a more urban community, vice versa, poor, rich, whatnot, the great dynamics. So I'm curious to know what your insights are. Thanks.
I think every healthcare has to be African thought and African trained, because I went to a medical school in Russia where I learned mostly is the heart attacks and cirrhosis of liver, because there's a lot of alcohol there. So I have no clue how to treat any infection. So I had to go back to school with my mom's school, because she was a physician before me. And as a physician, I think today worldwide we fail to think about mental health. We all focus on physical health, and we disassociate mental health of physical. So we have to rethink again. It's not only from Africa, it's the whole world, to think both healthcare in the physical and mental health, they have to go together. Because majority of the problem we have in the world is that someone who's mentally ill, was not discovered earlier, and is doing disaster for everywhere, in every corner of the world. So the tourism and everything we have, it's unstable children who got the gun in their hands. So if we could treat them early, even in high school, not going into the early age and thinking of their mental health and physical health together, we could achieve a lot. So I think a lot of things to do, and universities in healthcare, they have to focus on mental health too.
Yes, your question is really deep. You talk about all these policy issues, and you talk about maybe stigma as well, how we don't deal with mental health issues. First of all, as you said, these policies should be made locally, based on the realities on the ground. They should not be made in Switzerland by just the World Health Organization or by the World Bank. And as there are so many examples. I remember in a classroom at Dartmouth Medical School, we are studying infectious disease, and there's these wonderful professors. We got to the case of malaria, and he said, well, don't even worry about this. There's not going to be even a question, because you are never going to see these kind of problems here. Meanwhile, I'm from a place where malaria kills people every single day by hundreds. And whose fault is that? It's not the professor's fault. It's just how, what kind of illnesses do we want to deal with in different locations? This doesn't mean we should stop, studying, diseases that we see mostly in the Western world. No, but these should not be mutually exclusive. Mental health it's not a complicated issue. Nothing really is complicated. We are complicated people. We can afford to go to the moon. We cannot do something simple that we see in front of us. It's also an environmental condition issue. Those who are from Burundi, you know how the country suffered for decades. Trauma. It's in a country where there is no psychiatrist. In a country where someone who is stuck is in a desperate condition, is depressed, and then people run away from that person who needs us the most. And you end up having a country where almost everyone is suffering from PTSD. What is abnormal becomes the norm. So we started the mental health program 3 years ago, and we talked to quite a number of people who basically should have been able to think about this before we started that, and we worked towards some of the medications actually were not even allowed in the country. But we managed to do that, and we had this person from the US who is a board member, is a social worker, started talking about issues going on, domestic violence at home, gender-based violence at home, and asked, we had a community forum, and asked, is there anyone here who can come and meet me on Monday? Only 2 men and 3 women were able to raise their hands. So, okay, this is only a number of people who are going to meet on Monday. Guess what? On Monday, there were 97 people who showed up, and they showed up. They didn't want to talk about coming because of stigma. And we wondered, what is going on? Everyone had issues, internalizing issues, and they didn't want anyone else to know what was going on. So we started that way, and long story short, we have seen more than 100 people who were suicidal, who we put them on medications, now they're back home. Not only back home and being productive, they actually are now community health workers. They are moving around to train other people. There is health, there is care. We can just, deal with these issues. Back to policy issues. Are you from LA? Sorry? Yeah. Are you from the African Leadership Academy? No, you are not. He's a perfect example. This institution is a really true model for the African continent. Study, change policies that do not serve people. No one else is going to change. Not my mother, who didn't have a chance to go to school at all. She's going to suffer from these problems. You are the generation that is going to change these policies that are made out of ignorance, not because people hate you. They don't know. And they should, in the first place, be the ones to make these policies, because you have no education, and now you are being educated to make the policies and write the history based on your true history, not the history of other people, what they understand. That's all I can say.
Thank you. Thank you.
Hi, I'm Stella Nyanwe. I don't have a question, I have a few comments. I'm a former World Health Organization representative. My last job was WHO rep here in South Africa. And I have heard all that you've said. Every word is true. How can we sitting here fix it? We can't. Except we belong to the ruling class. That is, we must be part, you ALA students, you must come back, work, and be part of government. Because from the outside, you can't do it. In 2001, the African Ministers of Health agreed, each country, 53 of them then, before South Sudan joined us 54, that 15% of the budgets of their country will be dedicated to health. Do you know what proportion of them have got to 15%? Not up to 30%.
Right.
But we spend on arms, we spend on the army, we spend on the things which don't promote health.
Right.
Our ministers of health are health workers. Many of them are doctors. Can they make an impact on the Minister of Finance? Many times they can't.
Right.
So please, ALA students, come back home, work here, be in government so you can be the ones who can take these decisions and make us move.
Yes, thank you very much.
So first of all, they have to change the age of government. Oh, they have to wait until you're in 70s.
Good afternoon. My name is Sofia Chima. My name is Sofia Chima. I am a second-year student at the African Leadership Academy, and I actually plan on studying global health in the future. So my question to you is actually, what are your positions on utilizing traditional medicine as a means of reaching communities, rural communities? Because another issue, traditional medicine. Because another issue that is faced is the fact that a lot of people that are provided opportunities to go to modern facilities refuse to, because they are still, I don't want to say stuck in the past, but they refuse to accept that modern medicine works. So how can we utilize traditional medicine as a means to reach those rural places?
See, our doctors, after trying everything, they come with all these scars, they come with their, we too late to help them. My question is always this: why didn't you come earlier? And the answer is, I tried this voodoo guy, or this and that. It becomes a business. We actually have become a threat to some of these guys around, and we end up dealing with the chronic issues, health issues, that it's too late to change that. So how do you actually work with people? So again, community health workers are really important. We're trained, they know what is happening in the communities more than doctors and other healthcare providers who are in the hospitals or in the clinics. They can be our ambassadors, be the bridge linking these traditional healers and healthcare hospitals and the clinics. We have to work together with them and figure out what can we learn from what they are doing, and what can they learn from what we are doing, and have the synergy. Don't alienate, don't disparage them. It can cause really more problems than we can handle. That's number one. Number two.
Just end that so she can have the last word. Yeah, we have 2 minutes left. Yeah, sorry.
You said, well, so I think one thing I will add for my practice is it's a business. He's right. It's a business, it's a trust, it's a conversation. They have to trust you. The community has to trust you. You're taking care of them. So what we do as a Somalia, we have very few midwives. So most of the delivery done by traditional birth attendance. And we cannot just ignore them and kick them out. So what we did, if the case is complicated in our area, she brings to the hospital and we pay her same amount she's supposed to get. So it's easier for her, don't go all this trouble, don't cause fistula or anything. So this is the system we set up and it's working. So we need to work with them in many ways, as you say, as a conversation, as also as a financial capacity. And the same thing as FFG, we do female genital mutilation because of the business. So if you pay them and say, don't do this job, we will train you, don't cut the, it helps. So we need to think different angles. It's not only for having financial.
There's another, just quickly, you talked about the resistance. It's not them, it's education again. Yeah. How, we have some religious fundamentalists who basically tell people who are dying, don't go to see a doctor. So it's education. So your education, again, is extremely important. And it's not just for you to keep in your mind. Knowledge for what? When it's shared. You should spread it, and when people are educated, they are going to do the right thing.
All right, so can you join me in saying thank you to our panelists? And I know many people had questions to ask, but they didn't have the chance. So to make sure we're paying attention, there'll be a quiz, 1 minute. You just have to shout out one word you think is a theme that cut across all of the answers. So I will start first. Community health workers are very important. Anybody else? 5. One more? Education is important. Research is important. Policy. Solutions for Africa. Stop talking and do action. From this side of the room, one more person. Prevention, there we go. All right, so thank you very much. Enjoy lunch. All right, thank you very much. Nice to see you.